Hello, everybody. I would like to welcome you in this e-seminar, which is organized by the EuDial Working Group of the European Renal Association. There are some innovations going on in this webinar. The ERA is launching a real-time translation, both audio and captions, using artificial intelligence. And there will be a translation in 7 languages: French, German, Italian, Portuguese, Russian, Spanish, and Turkish. And you can access these translations by clicking on the globe icon at the bottom near the pause function, and you can choose your language. Also, for the captions, an external link which gives you access through the browser will be provided within the chat. And let me remind you that for those who are participating in this webinar now and are active members of the ERA, there will be a 1 European credit for CME. Of course, as long as they fill the mandatory questionnaire feedback at the end of the e-seminar. We have the honor to have an exceptional panel of experts with us today. Our main speaker, our main presenter, will be Professor Nikolaus Marx, who is a professor of medicine cardiology and head of the Department of Internal Medicine at the University Hospital of Aachen in Germany. And we will also have 2 excellent panelists with us. We are having Professor Karlien François, who is a professor of nephrology at the University Hospitals in Brussels, in Belgium, and she's leading the home dialysis program, and Professor Gabriel Choukroun, who is the head of the nephrology, dialysis, and transplantation at the Amiens University Hospital in France. Any questions can be can be sent to us through the question and answer function, and we will try to address as many questions as we can, either live or by replying to the question and answer session. So I would like to ask Professor Nikolaus Marx to start with his presentation regarding optimizing cardiovascular health in dialysis, which we all know is a very big issue in our patients on dialysis. So, Nico, please.
Thank you, Vassilios, for the kind introduction and for the invitation to deliver the lecture here at this symposium. I was asked to talk about optimizing cardiovascular health and dialysis. And what I'm going to do over the next 25 minutes or so to cover a short summary of cardiovascular risk in CKD, and then discuss the aspect of lipid-lowering therapy, anticoagulation in AFib, prevention of sudden cardiac death, effectiveness of interventional valve replacement for aortic stenosis, and finally, treatment of patients with heart failure and reduced ejection fraction. If you look at the changes in cardiovascular disease during chronic kidney disease progression, there's a difference here. It often starts with vascular disease and atherosclerosis, but over time, other manifestations of cardiovascular disease, such as left ventricular hypertrophy, arrhythmia, and then a very frequent reason, sudden cardiac death, is more important. And this has a major impact on the therapy. And this is due to very complex interaction. This just depicts a very simplified scheme that chronic kidney disease with activation of the RAS system, fluid retention, oxidative stress has an impact on the heart and the vasculature, leading, for example, to hypertrophy and fibrosis, while in contrast, cardiovascular disease then, through activation of the neurohormonal system and hyperperfusion, has an effect on the kidney. And of course, is you all know CKD is classified by eGFR and albuminuria. And if you look at the effect of changes in kidney function on cardiovascular disease, looking at eGFR here and UACR, if the eGFR drops below 70, below 60, there's a tremendous increase in heart failure depicted here in red, but also in cardiovascular mortality. And the same holds true if UACR increases above 5, with a steep increase in cardiovascular mortality and the incidence of heart failure. And the KDIGO heat map depicts the risk for kidney failure, the original heat map, but the same pattern, looking at UACR and eGFR, hold true for cardiovascular mortality and all-cause mortality. And this is something, I'm a cardiologist, this has been neglected by cardiologists because we were not aware of this for a long time. So let's look at different therapeutic strategies known to reduce cardiovascular risk and events in patients with cardiovascular disease. But once CKD is present, in particular in patients in dialysis, many of these strategies are not as established as they are in patients without dialysis. And looking at lipid-lowering therapy, there's the SHARP trial, including patients with CKD, those on dialysis, but also patients with CKD, looking whether the combination therapy of 20 milligrams simvastatin with ezetimibe compared to placebo leads to a reduction of the primary endpoint of cardiac death, non-fatal MI, stroke, or coronary revascularization. And the study, as you can see, has been published more than a decade ago. And in this trial, the combination of simvastatin plus ezetimibe led to a significant reduction of the primary endpoint compared to placebo, and the LDL difference between the groups was 32 milligram per deciliter. But in the context of our lecture day, it's important to see whether there's a difference in some patients on dialysis versus those not on dialysis. And you can see here the p-value for heterogeneity was not significant. First of all, demonstrating that there's no difference between the groups. But if you look in detail here, of course, the study was not powered for this. All is on the left line of unity. But for those on dialysis, it crosses the line of unity here, the standard deviation. But overall, these data suggest there's no difference. But then we have two cardiovascular outcome trials, the 4D trial and the Aurora trial, assessing the effect of an intensive statin lipid-lowering therapy, atorvastatin 20 or rosuvastatin, in patients on hemodialysis. And as you can see here, the primary endpoint here, combination of cardiovascular death, non-fatal MI, and stroke, and the same here, was not significantly reduced by the lipid-lowering therapy, suggesting that lipid lowering in a patient population on dialysis is less effective compared to patients without CKD, but also compared to patients with CKD who are not on hemodialysis. And if you look at the European guidelines on cardiovascular disease prevention and clinical practice, there's a clear class 1A recommendation that the use of statins or statin-ezetimibe combination is recommended in patients with non-dialysis dependent stage 3 to 5 CKD. But then in patients already on statins, ezetimibe, or the combination therapy at the time of dialysis initiation, it should be considered to be continued. That's a weaker recommendation, class 2A, and the level of evidence is C. C in the language of ESC means it's expert consensus, while here A is based on evidence. And then there's a class 3 recommendation in patients with dialysis-dependent CKD who are free of ASCVD. Commencing statin therapy is not recommended, and this is a clear negative recommendation with the level of evidence A. Let's look at anticoagulation in patients with atrial fibrillation on hemodialysis. And first of all, let's look at the prevalence of AFib in these patients. This is North America, Japan, and Europe. And you can see in an age-dependent manner, there's a strong increase in the prevalence of atrial fibrillation. And as you know, in particular in elderly patients above the age of 65, but even more in those above the age of 75, patients at this age with AFib have a highly increased risk for a thrombotic event and for stroke, thromboembolic event and stroke. And if you look at the way we assess the risk of stroke in patients with AFib, we use, according to the ESC guidelines, the Schätz-Vass score, which gives a point for heart failure, hypertension, age, diabetes, thromboembolism or stroke and others. And at the same time, we look at the bleeding risk, but very important here, the problems in CKD patients is that this score was established for patients without CKD, and in patients with dialysis, we have the stroke risk, but also a very high risk of bleeding. And let's look at the data. What kind of data do we have? And there's a very nice analysis published in 2009 already, looking at about 50,000 incident HD patients from the US with AFib at start of dialysis, comparing strategies, clopidogrel versus none versus coumarin. And you can see here that stroke prevention was not as efficient in coumarin-treated patients compared to those on clopidogrel or non-dialysis. And if you look at some other data here, 2,300 patients, elderly patients who initiate dialysis on new onset atrial fibrillation, 250 received warfarin within a 30-day window. And then there was a propensity score matching with these 237 with non-users, and then looking at mortality, ischemic stroke and hemorrhagic stroke. And you can see there's not much of a difference, but you can see a tremendous increase in those receiving warfarin. This is not a randomized trial, but it suggests that there's an increased intracranial bleeding risk, while there's no difference with respect to ischemic stroke. And then there's data from a Danish registry looking at patients with a non-valvular AFib, comparing no therapy in no CKD, CKD, and those on hemodialysis. And you can see these data suggest here that warfarin compared to no therapy reduces the risk of stroke. So there's indeed conflicting data how to deal with the anticoagulation. No clear evidence, conflicting data, from registries, but a very important point that needs to be taken into consideration when starting warfarin, for example, is the risk of calciphylaxis here. And this is data coming from our department here, demonstrating that there's an increased calcification risk both in the valve as well as the coronary arteries in hemodialysis patients receiving warfarin versus no warfarin. And there's this very increased risk. We are having a register here for calciphylaxis and showing that clinical characteristics of patients developing calciphylaxis here is the use of warfarin, and therefore one should take also this into consideration. In summary, in dialysis patients with AFib, the risk-benefit ratio of anticoagulation therapy with VKA is unclear, needs careful consideration. What do the guidelines say? And the European guidelines for AFib state that in patients with a clearance between 50 and 29, RCT-derived data on the effect of vitamin K antagonists on NOACs are lacking. Basically, we don't know it, there are no data, and the evidence for the benefits of oral anticoagulation in patients with end-stage kidney disease with an eGFR of 15 or less or on dialysis is even more limited and to some extent controversial. Summarizing what I discussed with you and presented to you, this is an open question. This is published in 2020, and in a year later, a meta-analysis was published summarizing all the available evidence using pairwise meta-analysis and Bayesian network meta-analysis, showing that based on ACT, RCTs and observational data, DOACs or NOACs are superior to warfarin in patients with an eGFR between 15 to 60. Oral anticoagulations without significant benefits are on patients on hemodialysis because there's the reduction of stroke, but on the other hand, the high bleeding risk. And based on the analysis conducted here, comparing DOACs, dose-adjusted apixaban seems to be superior to other DOACs in patients with AF and an eGFR between 25 or 30 to 60. But again, this is a meta-analysis, a Bayesian network analysis suggesting that there might be a benefit, but it's not a head-to-head trial and no clear comparison. And the guidelines for cardiologists summarize that, and they're saying that in patients with hemodialysis, it is not recommended to use non-vitamin K antagonistic oral anticoagulants. Let's look at prevention of cardiac death in CKD. If you look at the cause of death in patients on hemodialysis, you can see here, this is sudden cardiac death, this is cardiac non-sudden death, this is cardiac death and others. And you can see once the eGFR drops and patients develop or need hemodialysis, there's a tremendous increase in sudden cardiac death. And this is something also shown in large trials for the 4D trial. And we conducted a recurrent event analysis, and sudden cardiac death remains the main cause of death in patients on hemodialysis. And the question is how to prevent that. And specific preventive measures could be the use of beta blockers, the use of implantable cardiodefibrillators in those with a low ejection fraction. The risk of cardiac death is due to dialysis-related factors, but also due to other risk factors, and they all together could contribute to a global risk reduction. But let's look at specific preventive measures, and this is a meta-analysis looking at the effect of beta blocker therapy on cardiovascular mortality in dialysis patients here, looking at carvedilol, nebivolol, and carvedilol. Again, here different trials here, this one in dialysis patients, these in non-dialysis, and all on the left line of unity is suggesting that beta blocker therapy reduces cardiovascular death in patients with CKD, but as a word of caution, there's an increased risk of bradycardia and hypotension phases with beta blockers, especially, for example, post-hemodialysis. What about ICDs? Mortality after ICD implantation in dialysis patients here. And you can see here the curve. This is an observational study in those receiving an ICD versus no ICD. So there seemed to be a certain benefit. Still, if you look at the mortality after ICD implantation for dialysis patients here, you can see compared to those not on hemodialysis, there's a higher mortality suggesting that the prevention by just implanting a defibrillator is not really or not tremendously reduced. And again, there's a higher risk of infection and bleeding after implantation and more frequent stenosis and occlusion of the subclavian vein on the dialysis access side once you implant the defibrillator. So in summary, there are no clear therapeutic strategies for the prevention of sudden cardiac death in dialysis patients, having in mind that sudden cardiac death in half of the patient is the leading cause of death. So there's certainly room for improvement here to develop novel therapeutic strategies. Let's move to an interventional topic in cardiology, which is valve replacement, not by surgery, but by an intervention in patients with aortic stenosis. You know that there are established techniques now already established 15, 20 years ago, where through a transfemoral approach, and this is what we usually do in 98% of the cases, and we used to do it in the transapical approach in high-risk patients. And this TAVI strategy has shown superiority compared to surgery in high-risk patients here. The question is this benefit also true in patients with CKD? And there's been a very nice analysis published a decade ago with the objective to investigate the prognostic significance of chronic renal insufficiency in TAVI patients. A multi-center registry study, total of 2,000 patients from 9 centers, and a follow-up up to 3 years. And the primary endpoint, total mortality. This is freedom of all-cause mortality in patients CKD stage 1 and 2, stage 3, stage 4, and stage 5 after 12 and 24 months. And as you can see here, patients CKD stage 5 have a mortality of 50% after 2 years, which is much lower compared to patients with CKD stage 1 and 2, for example. And then there's an additional aspect here depicted looking on patients with dialysis or no dialysis, with or without atrial fibrillation. And look at the blue line here. Patients with atrial fibrillation have an increased mortality, so shown here. But if you compare dialysis versus no dialysis, after 1 year, there's not much of a difference, but then the curves kind of diverge. Of course, this is small numbers here at the end, but a very important message for me, and this is relevant for clinical practice, and we are having a large interventional group here in our department. If a patient with aortic stenosis is on hemodialysis and has atrial fibrillation, he has a very, very high mortality already after 12 months. Again, this is small numbers, but this is clinically relevant because when we look at the patients and see that they have aortic stenosis, AFib, and are on dialysis, we are very hesitant to do the procedure because we know that the mortality is very high. So in summary, there's a significantly increased mortality after TAVI in patients with chronic renal insufficiency on dialysis and atrial fibrillation, so a very special population. Finally, let me spend a few slides on the treatment of heart failure with reduced ejection fraction in CKD. In heart failure treatment for reduced ejection fraction, we have what is now called the Fantastic Four, which is ARNIs, ACE inhibitors, MRAs, beta blockers, and SGLT2 inhibitors. And if you look at the different drugs here, up to an eGFR of 30, so CKD stage 1 to 3, the drugs are approved. There's good evidence for a benefit for all of them: ACE inhibitors, beta blockers, MRAs, ARNIs, and SGLT2 inhibitors. But once the eGFR drops below 30, there's no evidence for MRAs and ARNIs, no evidence for any benefit, and MRAs are contraindicated in some countries. The best evidence we are still having here is for beta blockers, moderate evidence for ACE inhibitors, and we have evidence that SGLT2 inhibitors exhibit a beneficial effect if the eGFR is above 20. Below 20, we don't have data. Usually, we continue therapy in these patients if the eGFR drops. But you can see of the Fantastic Four here, only 2 remain in patients with impaired kidney function below 20. So where's the evidence for the different trials? Again, summarizing the strategies, if the eGFR is above 30, we don't have a problem. But if it drops, here, in addition to the medical therapy, also is depicted, for example, ICD, secondary primary prevention. You can see here, once dialysis is indicated, there's very weak or even no evidence. And so in patients on hemodialysis, heart failure treatment is very, very difficult because we don't have evidence. and the patients with heart failure on hemodialysis and have a very high risk and no well-established strategy to reduce events. And this is due to a very complex interaction between the heart, the kidney, and the vessel wall, with various factors that contribute and interact to cardiovascular morbidity and mortality, such as oxidative stress, inflammation, fibrosis, but also post-translational modification of peptides and proteins that we see in patients with CKD. And in Aachen here, we do have the special research consortiums combining the expertise of cardiologists and nephrologists to tackle some of the questions here, but there's a lot of work to do. And with that, I'd like to thank you for your attention, and I'm looking forward to our discussion. Thank you very much.
Thank you very much, Professor Marx, for this state-of-the-art presentation. Now we will have some comments from our panelists, and I would like to ask Professor Karlien François to make a few comments. Karlien, please.
Yes. Good afternoon, everybody. Thank you very much. Thank you very much, Vassilios, for guiding us through this very interesting webinar with many clinical questions during our everyday practice. I would like to make a comment on another frequently applied cardiovascular preventive treatment, being physical activity, because we all know that for our patients presenting cardiovascular risk factors, we do try to stimulate them to move. And the question is whether we still need to do this for our patients in dialysis. And recently, the results of the DIAT trial were published in the New England Journal of Medicine Evidence. And this was a randomized controlled trial of where intradialytic exercise treatment was tested against usual care. So patients were either enrolled in a program of intradialytic training, both resistance training and endurance training, or they got usual advice on physical therapy. 1/3 of the patients had known coronary artery disease, and 1/3 had known diabetes mellitus. And actually, after 12 months, there was a significant improvement in sit to standing, and also after 1 year, the number of days admitted to the hospitals was significantly lower in the patients who received intradialytic therapy. So I think we really need to keep our eyes open, and this study supports also previous data on surrogate markers such as vascular resistance markers, that physical exercise during dialysis might also help to improve the outcomes of our dialysis patients. This was basically my first comment I would like to make.
Thank you very much, Karlien. This is very important. The role of physical activity is really important, and we have a very good experience in our center, and I think that patients really are really helped by this. They also like it, and it improves their quality of life as well. And then Professor Gabriel Choukroun, please, would like to listen to some of your comments.
Yes, thank you very much, Vassilios, and thank you, Professor Marx, for this very nice presentation on the optimizing cardiovascular health in dialysis. Cardiovascular remain the leading cause of death in cardiovascular patient, on CKD patient, sorry, including, of course, dialysis patient. And even a number of progress have been done the last decades to improve the care of patients with cardiovascular condition, new drugs, new procedures. We feel as a nephrologist that this progress will not very much translate to our CKD patient at least dialysis patients. And we have now several trials who were done on dialysis patients. Most of them are negative. You show the result with statins. We have a trial with erythropoiesis agents, sinacalcet, ACE inhibitor. And now we just learned that mineralocorticoid receptor antagonists also fail to demonstrate a benefit in cardiovascular protection, mortality in dialysis patients. We had the results of the Alchemist trial present at the last ESN. And this trial compare spironolactone 12.5 to 25 milligrams to placebo in high-risk dialysis patient. And again, this trial was negative. So I don't know if you have an explanation for that, or all of us may comment. Why is it so difficult for dialysis patients to get benefit of these many drugs that are so effective in the general population?
Maybe I can start addressing that. I think the main point is that the pathophysiology of cardiovascular disease once the patient is on hemodialysis is different. Calcification plays a role in the vessel wall. We have stiffness of the vessel wall. Then in the heart, we have fibrosis, we have hypertrophy, and the classical stabilization of arteriosclerotic lesions by lipid-lowering therapy, wonderful strategy to reduce plaque burden and prevent acute events, is just not working. And in addition to that, and that's what I learned from my nephrology friends, that dialysis, of course, is important, but patients on dialysis have post-translational modification of certain proteins. We identified, for example, that atrial natriuretic peptide is a vasodilatant, is chrysolated in patients with CKD, losing its function. So the degree of complexity is very high. And I think the first step is a better understanding, but our thinking that we can extrapolate strategies that are efficient in non-dialysis patients or non-CKD patients can be easily translated is just wrong. It's more of a broader explanation. It's a kind of no-brainer, but it, on a daily practice, it's very difficult.
Yeah, maybe I can also add a comment on that. So I fully agree, of course, with your line of thoughts. And I think this also proves that it's so difficult to conduct clinical trials and to try to find answers, because in many of the dialysis, first of all, many of the dialysis trials focused on hemodialysis patients, and so already many of the data might not be applicable for peritoneal dialysis patients, and also many of these studies included prevalent patients. And the question is, if we would include only incident patients and eventually only incident kidney failure patients with a particular renal diseases, maybe the outcomes would be completely different, because the pathophysiology of the renal disease and the pathophysiology of cardiovascular comorbidities are different at start of the dialysis. So I really think that we need to be very careful when generalizing the data, and this makes it sometimes very difficult in our clinical practice.
Karlien, I couldn't agree more. I think it's the word is a little overused, but we need personalized medicine. You know, we were spoiled with statins. Statins basically work in everybody, so it's the one-fits-all concept, and this is not true in hemodialysis. And I love your approach, and it requires a better understanding of the pathophysiology. And I think it's a good idea to start with patients that just develop or need dialysis. Yeah. They're not too.
This will make it more difficult to run the trials.
I know, but once someone is on hemodialysis for let's say a few years, he's so far down the road that it's very difficult to reverse the process.
I think we all agree that it is the burden of cardiovascular disease is so high, and it adds up by the dialysis vintage as more years on dialysis. Then I think it is probably or too late or too little what we can do.
Yeah.
Okay. I think that maybe if everybody agrees, I don't know if Gabriel has something else to add, probably.
I will have a question later for Nikolaus on TAVI.
Okay.
If you give me back the...
Maybe you can ask the question now, and then we can go to the questions,
go
because
ahead.
there are some questions
No,
from the
just
audience.
with the same line. What is the main problem in dialysis patient? We know that aortic stenosis is very prevalent in this population, calcification, vascular calcification also, and you show that the risk in dialysis patient with this procedure is very high. What is for you the limit? Is it the age of the patient, the importance of the calcification, of valvular calcification, the comorbidity? What is the main limitation or some of the main limitation? Why those? I mean, I know part of the answer, of course, but why this is so difficult in this population for you?
Yeah, Gabriel, excellent question. Just to avoid a misunderstanding, the risk during the procedure in dialysis patients is a little higher, but that's not the point. The critical point is a summary of a couple of things. Often in dialysis patients, valves are really calcified, and you implant the new valve, and one driver for an increase in mortality is paravalvular leakage. So imagine if you're having a very calcified valve and implant another one, if it's kind of stone material, and there's often a leakage, that an aortic insufficiency that causes a problem. Then, of course, by implanting a valve, you do not reduce the always present risk of sudden cardiac death of arrhythmias, for example. So it's procedure, or not procedure related, but fact related, that this is TAVI and the additional risk. And another point is that the ventricle in dialysis patient often is very stiff, and remodeling that we often see once we open the valve again, this is not taking place. And this is also a mechanism that is considered or is thought to contribute to that.
Thank you. Yeah.
Yes, excellent. Okay, thank you. Now, I think we can go through the questions if the panel agrees. Of course, most of these questions have been answered during Professor Marx's talk. May I go through and I can pass the question to some of you. ARNIS in advanced stage, I think you've answered that already. It's one of the fantastic four that we cannot, we have no data, okay? Is it fantastic four or five? Because it's ARNIS and...
Yeah, excellent question. So usually we put ACE inhibitors and ARNIS in one basket.
Okay.
And usually now we start with ARNIS even in the hospital right away, because otherwise you need to stop the ACE inhibitor. So it's the fantastic four, and this two are put in one group.
Okay, thank you. So it's also about beta blockers. You've answered that, and ACE inhibitors. There is some evidence.
Yeah, but it's weak evidence. You know, the strong data published more than 20 years ago for ACE inhibitors in heart failure were kind of groundbreaking, and this is certainly not true on hemodialysis. But as shown, the best evidence is still for patients on beta blockers.
Okay, so beta blockers have the best evidence. Yes.
Yeah, if I may, I would just like to add, although the evidence is poor on the use of ACE inhibitors and the cardiovascular effects in dialysis patients, I think one of our main goals in dialysis should also be to maintain residual kidney function, because we know that residual diuresis is the one of the most important factors determining outcomes and survival, and ACE inhibitors might play a role, especially in proteinuric kidney disease, to better preserve residual kidney function. So in my personal practice, we will really push forward to keep the ACE or ARBs on, in the treatment plan. And regarding the ARNIs, despite just a personal word, we do have some patients on ARNI in dialysis, basically those who were on ARNI, and we just keep on giving them through once they started dialysis.
Yeah, very, very good point. If I may chip in, we're doing the same actually in clinical practice. Absolutely. My statement on prognosis was very cardiocentric. And of course, we keep the patient on ACE inhibitors and also on ARNIs. Point well taken. Thank you.
Of course, residual diuresis is very important, even for heart failure or heart events prevention. Yes, of course. Now, next, dialysis temperature and calcium, and the role of calcium in vascular calcification. If somebody wants to make a comment on temperature, Karlien or Gabriel, this is a nephrologist.
I can just tell that there was a recent the MyTemp trial was recently published, and unfortunately did not show any benefits of decreasing dialysate temperature. So we don't have any evidence that decreasing the dialysate temperature will improve cardiovascular outcomes in our dialysis patients. Although this has been proposed also as a mechanism of protection, for example, during hemodiafiltration, because there is more cooling during HDF compared to during HD, but we don't have profound evidence that reducing dialysate temperature will improve outcomes.
Yes, if I may add, there is some ongoing issues about cool dialysate and that, but not any real evidence, at least yet, maybe in the future. Any comment about calcium and maybe?
Yeah. I can take that question. Short answer, don't use it in patients on dialysis, because you're having calcifications all over the place, even in advanced CKD. Don't use it. It doesn't give you any answer, because you need to know whether it's intravascular, in the vessel wall. There's so much calcification, not standardized, not validated. Don't use it.
And there's similar the CAC scores and everything. Yeah. Okay, thank you. Best way to adjust volume status in dialysis patients with heart failure. We have discussed a little bit about that just before the start of this seminar. If I may say, the peritoneal dialysis has a role. There are no randomized trials, but all of us have a positive experience with peritoneal dialysis patients and heart failure. I don't know if it improves mortality or it improves survival, if it improves survival, but it's for sure that it improves quality of life and it reduces hospitalizations. That has been, I think, published in small observational, mainly trials. If anybody else wants to add something. Okay. Thank you. The statins, we have discussed on statins a lot. And is there any evidence on PCSK9? I'm not at least aware. No.
Nope.
Okay. About DOACs, Professor Marx has, I think, clearly made the points. you have to consider the risk and benefit always,
Yeah.
and there is no evidence about DOACs in dialysis patients, if I'm correct. If diabetes worsens risk, Karlien, sorry.
Yeah, again, if I may, sorry to disturb you, but just I also wanted to make the point that regarding the DOACs, unfortunately, there is a true knowledge gap again between hemodialysis and peritoneal dialysis, and all the data on AFib and DOAC use is almost completely focused on HD patients. So for me, it's really a daily burning question. What should I do with my AFib peritoneal dialysis patient? I think we don't have the evidence, or at least as far as I know. And in my personal clinic, we are much more tolerant to start anticoagulation in PD patients compared to HD patients, basically because their bleeding risk is significantly lower, and this is most likely due to the fact that they don't receive the HD associated anticoagulation. And there, so we all know that there is now the novel treatments in the pipeline, the factor 11 inhibitors. And I think as a nephrology community, we should really try to stimulate the industry to continue the research of factor 11 inhibitors in dialysis population, so that we don't get up at the same point as with the DOACs in 10 years from now. And unfortunately, it does not seem to move the right way.
That's right.
Yeah.
Probably they will exclude patients on dialysis from all trials as they have done in the past, and that's why we don't have any.
But we do have very promising phase 2 trials of factor 11 inhibitors in dialysis patients, and hopefully the industry will change their mind and continue phase 3 trials in dialysis patients.
I think there are going to be some phase 3 trials, because I think somebody has contacted us about something like that. We'll see. Okay, is diabetes okay? Of course, diabetic patients have a higher risk of cardiovascular disease. I think that's for sure. Another question. What is the central blood pressure, and what is the effect of different antihypertension, especially beta blockers, on it? If somebody wants to make a comment, I haven't actually understood the question.
Yes.
Okay,
I'm not sure that I understand the question. The central blood pressure is something that in clinical daily practice we don't really measure or evaluate. There's some interesting experimental data, but this is far out of our clinical daily practice.
Okay. Now, maybe Professor Max, you can answer that. Would you recommend left atrial appendage closure in patients with atrial fibrillation on
very interesting question. Together with my nephrology friend Jürgen Flöge here, we discussed this pretty often, because ideally the HD patient would be the ideal candidate, because you prevent embolism and don't need to anticoagulate. There's, to my knowledge, no trial finished on that. There's an ongoing trial there, but our enthusiasm for the left appendage closure is also a little diminished, because we now more and more see patients that still develop a thrombus on top of the closure device, which is something that is currently under investigation. So theoretically, a very good population, and in some elective patients we're doing it, but there's no data suggesting in a broad population of HD patients that this would be beneficial. So we don't have the data.
Okay, about intradialytic exercise and stunning of the heart and brain. Karlien, you know something about that? I'm not aware of something.
I'm not aware of this particular cerebral imaging data or myocardial data. No.
Yeah, there's some data in the heart echo data using the strain analysis suggesting that there's some effect, but the clinical relevance of that is unclear.
And how can we control for patients who have resistant hypertension on dialysis? Well, before passing the question, I must say that in most dialysis patients, hypertension is volume related. So usually you have to lower the weight. After that is made, and this is a little difficult sometimes. Difficult for many reasons, and some of them are patient related, and their attitude towards reducing the dry weight. I don't know if you have another comment, somebody.
No, I agree with you. I agree with you, and maybe Karlien, there is less hypertension in resistant hypertension or difficult to control hypertension in PD patient, and this is probably explained by the volume, which is more difficult to control in some dialysis patients. So I agree with you. Most of the time, it's volume dependent, and we have to decrease the dry weight, which is not so easy to do.
Oh, yes, and if I may, so on peritoneal dialysis, there is a special role of icodextrin in achieving a better dry weight, and we must not forget that. And maybe we could use icodextrin more often or earlier sometimes. Okay. I think the next question is more or less the same about to eliminate sufficient fluid. Okay. And of course, residual diuresis is very important, as Karlien pointed out, even if in achieving dry weight. But of course, when we measure residual diuresis, we must also have in mind that in euvolemic patients, because in overhydrated patients, they may have some diuresis, but this is in expense of overhydration. Okay, and yes, I think the next question, yes, we can use body composition monitoring is one of the tools that we may have in assessing dry weight and euvolemia in our patients. We have some experience with body composition monitoring, but it's not, I mean, it's not something that is really necessary, but it is an additional tool. That at least this is my experience. If there is any comment on that.
Well, I think the trials were negative. The BCM trials were unfortunately all negative.
There is okay.
Just but if I know, I agree. I mean, I think this is the $1 million question. Is my patient congestive, yes or no? I mean, there is I think you need to follow trends and do a scala of exams and not just confined to one single test. Yeah,
I fully agree. Either body composition monitoring or this lung ultrasound or this or the cardiologists with their usual ultrasound, they can give us a lot of information, but it's also always clinical judgment and how you see the patient. You have to see the patient. You have to be near the patient, and at least as nephrologists at least every 2 days. Is there a difference between HF with preserved or with reduced injection fraction when it comes to management of dialysis patients? Is there?
Yeah, it's the question is whether it comes to outcomes or management. For outcomes, usually the prognosis on those with HFrEF is a little worse than those with HFpEF. And the management, of course, for the management of those with HFpEF, the only established therapy, but in non-dialysis patients, to improve the prognosis in HFpEF is SGLT2 inhibitors. while for patients with HFrEF, we have good evidence for ARNIs and beta blockers, which we don't have. But I'm not aware of any data, but I think dialysis is such a driver for outcome independent of the management here. I think it's very hard to distinguish and give a clear answer here.
Okay, thank you, Nico. Okay, if we could start earlier preventive measures in CKD patients, I think this is answered by itself. Okay, of course, the earlier the better. And we have a lot of tools, a lot of weapons in earlier CKD than we have in patients on dialysis, and we don't have these very high cardiovascular burdens. SGLT2 inhibitors in hemodialysis patients, that has been answered by Professor Marx. I think it has been made very clear. There is no indication, but usually we continue. There is some evidence that we can continue, at least in patients who have residual diuresis. The use of high calcium dialysate, we have answered that about calcium before. There is a question about SGLT2s in less than 20 GFR, even without renal function.
Yeah, there's some data from the EMPA-KIDNEY trial that included patients even with a lower eGFR, and the patients were kept on the SGLT2 inhibitor, even on dialysis. And there's an ongoing trial. I think, Karlien, you mentioned that the ongoing trial in patients on dialysis with the question, even if there's no urine excretion anymore, what is the effectiveness? But I don't know. We'll see the data, I think.
And the renal life cycle study will only include dialysis patients with residual diuresis.
Right.
So the secondary effects or pleiotropic effects of SGLT2 inhibitors on metabolic processes in anuric patients. This is a question to be answered.
Yeah, a difficult one. Yeah.
Maybe in the future of the future, because first we have to answer.
Maybe not for the next webinar on this topic, but
okay. And ACE inhibitors and potassium levels in dialysis patients, it's always an issue. Yes. Okay.
Well, this is less of an issue in peritoneal dialysis most of the times.
Yes.
But,
Professor François is a fan of peritoneal dialysis, and I'm very happy about that.
I need to disclose that one, yes.
I'm also a big fan of peritoneal dialysis, but unfortunately in Greece, as in many other countries, there are not many patients on peritoneal dialysis. There are, I think, less than they should be on peritoneal dialysis. And this is another interesting question. Which beta blocker do we prefer in dialysis patients?
Well, if you look at the evidence, if you look at the evidence, carvedilol is used, and which has a beta blocker, but also alpha component, which leads to vasodilation. We've some good data here, and otherwise nebivolol, which is a beta 1 selective one. That's what we use. Okay.
I think I agree with you, Professor Marx. And if initiation of dialysis can impact injection fraction,
difficult question. I think once you start dialysis, additional pathophysiological mechanisms kick in. There's an increase in fibrosis and post-translational modification, which over time may have an impact on the ejection fraction, but I'm not aware of any longitudinal large population data.
Okay, and Karlien, if you can give us again the name of this study.
This is the renal life cycle study, and it's run by the Dutch Kidney Foundation. So it's from the Netherlands. It's the team of Ron Gansevoort who runs the trial.
Okay, Thank you very much. I think we're at the end of this webinar. I personally enjoyed it very much, and I enjoyed our conversation, and I enjoyed all the questions. And we all agree that patients on dialysis have a very high cardiovascular burden, and we have that it is in some way different than the usual cardiovascular disease in non-dialysis patients, and we have less weapons, less tools to deal with that. But we hope that we will have more weapons in the future, and we can improve survival and quality of life of our patients with pharmaceutical interventions, but also with lifestyle interventions like Professor François pointed out, exercise. So I would like to thank everybody for this excellent webinar. I would like to thank the ERA and the organizers. I would like to thank Professor Marx for his excellent presentation, and Professor François and Professor Choukroun for this their valuable comments and this excellent discussion that we had. And thank all of you for participating and listening to us for 1 hour. So thank you very much, and hope to see you again.